Greetings from Manila. And on this day of the celebration of the World Coma Day, I would like to congratulate each one of you for having the interest in improving our care for the coma patient. I was invited to discuss on the evolution of bedside nursing in the care of patients with coma. For this particular topic, I would like to say that I have nothing to disclose. So let me begin by saying that evolution is a unifying principle that helps in us in understanding the phenomena in life and other fields such as diverse as medicine and nursing. This knowledge is important not just from the scientific perspective, but from a practical one as well. Now, the evolution of coma presented major breakthroughs in the understanding of the mechanism of this particular illness, the role of the increase in intracranial pressure, and its clinical correlates. This particular knowledge provided a description of how different categories of coma have been defined and tools of prognostication were also understood. Now, the evolution of medical understanding of coma started way back in the 17th century, and apoplexy was used to describe impaired consciousness. There were terminologies, causes, observation, treatment, and breathing movements and pathophysiology related to impaired consciousness that were explored. Likewise, early nursing or bedside care began in the home. Family members would care for the sick where they lived before hospitals existed. Sometime around 300 AD, some of the first illness facilities emerged in the Roman Empire, and the first written documentation about nursing were also during this particular era. Among the illness cared for was impaired consciousness, which was then called apoplexy, which comes from the Greek word apoplexia, meaning to be struck down utterly by the gods. In Merville's day, which is 1819 to 1991, the word was used as a blanket term to refer to any sickness caused by an infusion of blood or serum in the brain that resulted in the loss of consciousness or death. The term was used more widely before advancement in medical science allowed for more sophisticated distinction concerning the causes of illness or death. Nowadays, that what was once known as apoplexy would be interpreted as stroke or heart attack. And the term apoplexy is still in use today to describe sudden loss in the influx of blood flow to a particular organ, as in adrenal apoplexy and your pituitary apoplexy. So moving on, in the 18th century, the coma phenomenon was of predominant interest for physicians as well as lay people through the ages and was usually associated with drowning victims. And this is often referred to in the titles as apparently dead, heightened by the fear of being buried alive. Drowning persons were supposed to be brought inside a house, their airways inspected, wet clothes removed, warmed up by rubbing or with woolen clothes or and administering tobacco smoke fumigation by the rectum. Following this warming up, bleeding could be applied from the arm or neck, but not too superfluous. Only if signs of swallowing acts were observed, some hard liquor could be poured down in the mouth, and the rapid spirit of ammonia with ammonia salt will be kept under the nose if this particular liquid drain were not effective. The person should be laid in a preheated bed accompanied by a naked person who provided the natural heat. Now, next to the coma in droning person, There was another aspect of apparently dead, notably a great fear for being buried alive. In 1891, the Italian psychiatrist Enrico Morselli described tapephobia, defining it as an extreme condition of claustrophobia due to the fear of being buried alive. This particular rare pathological condition is, of course, reflected in an ancient fear, and its origin is yet unknown. The English physician John Potterhill suggested that in some situation it might be profitable to distend the lungs with air, in particular in those cases with sudden deaths. The cause can be apoplexy, it's of various kinds, as hysteria, syncope, and other disorders. Next to artificial ventilation, the use of electric shock, which was, of course, not unexpected in this age of medical electricity, was also recommended as treatment to determine if the patient is alive or dead. In the 18th and 19th century, nursing was transformed from a domestic duty of caring, which we consider wet nursing. Nurses were now hired by strangers to care for the sick family members at home, and their primary role was to separate the sick from the and potentially contagious individuals from the healthy population. Now, modern nursing is said to have begun around 1845 when Florence Nightingale led several women in treating the sick and injured during the Crimean War. Her treatment practices set new standards for nursing care, and she believes that the main problem in that particular time were dirt, diet, and drains, or in relation to sanitation. She was one of the first in Europe to grasp the principle of the new science of statistics and to apply them to military and later civilian hospitals. Physical examination of the patient was gradually introduced in the course of the 19th century and the beginning of the 20th century. There were several observations in the comatose patient that followed the experimental findings. Of this observation of the pupils were first noted by Chine in 1812, who observed that narrow pupils, uh, who observed the narrow pupil. His name became associated with the Chine stroke breathing pattern, and he described the symptoms of an approaching death in patients suffering from apoplexy, such as the organs of sense entirely lost their faculty of receiving impressions, the pharynx is insensible, the pupils become dilated, and the eyes opaque. And now the jaw would fall. There were several levels of unconsciousness, and it was possible to make a prognosis from the quantity of sensory power which still exists in the body. Therefore, he also claimed that we should not despair until the pupil ceases to contract, and with any return of sensibility, our hope for life should rise. At this time, the common activities that nurses perform in their job included the following: taking vital signs, drawing blood samples, recording medical history, assessing, determining symptoms, conducting physical examination, and the like. And as you can see, I have highlighted here some of those very, very important jobs that the nurses must be able to perform in order to make the patient live. So moving on, we would say that at this particular time, there was very little technology that was in place to assess in the monitoring of the patient. The temperature was taken with the mercurial thermometer, and you have to wear a pin watch for the counting of the patient's pulse and respiration. And the blood pressure was measured with an aneroid sphygmomanometer. In the general ward, each bed did not have any oxygen supply. You have to wheel in a portable oxygen cylinder when the patient would need one. Your IV fluids will come in glass bottle and you need to control the speed of administration by either counting the drops per minute or you have to stick on a length of tape on which you mark the minutes and hours it has been flowing. Now, physical examination was largely confined to palpating the pulse and the inspection of the urine, the feces, the sputum, and the pus. The observations on arousal to sensory stimuli was done by shouting, pinching, applying stimuli to the nostril. Here you will have to observe movements of breathing and describe it, then mention a full and strong pulse that became weak, small, and frequent, and observation will help guide the grading of the level of consciousness, or what we call unconsciousness too. In 1977, a Larmont paper on the aspect of coma following severe head injury was published, and this presented a new scale for grading the level of consciousness after the head trauma. So the next evolution of nursing was in education. As advancement in medicine brought better treatment and care in the 1900s, the nursing profession was then subjected to stricter requirements, and that this has to be produced by means of education and experience. Technology began to play a larger role in nursing, and advanced patient beds, stethoscopes, and blood pressure were devices became the norm in bedside nursing. The evolution of nursing continued, and advances in technology and medicine created the need for more educated nurses. Nursing education moved from the hospital to the classroom. Certification programs emerged, allowing nurses to perform certain duties. And by the 1960s, specialized nursing began to emerge. Nurses would be trained on intensive care units or other specialty. The nurse responsibility has expanded over time with the heightened importance of patient safety and advanced nursing practice, which applies science and technology to help improve healthcare delivery. Literatures have emphasized at least two key themes in the 21st century nursing care. It is said that nursing is important for safe, quality care provision, and nursing is as important for the humane, compassionate treatment of patients, inclusive of the emotional, psychological support of patients when it is necessary. So, evidence based practice is most important because it aims to provide the most effective care that is available with the aim of improving patient outcome. It promotes an attitude of helping us to think of why am I doing this in this way? Or is there evidence that can guide me as a nurse to do this in a more effective way? Part of providing professional service is ensuring that our practice is informed by the best available evidence and to ensure that finite health resources are used wisely and that relevant evidence is considered when decisions are made. So in 2019, the Neurocritical Care Society launched the Curing Coma, and this was considered as the first multidisciplinary global public health initiative to tackle the unifying concept of coma as a treatable medical entity. The goal of Curing Coma is to address the grand challenge by developing and implementing coma treatment strategies that improve human lives. So the core phenomenon or core patient problem and the core intervention comprise the nursing practice. In the YouTube presentation of Daiwa Olson, who is the co-chair of the Curing Coma campaign, he explained the difference in the context of caring about caring for, and curing from. He stated that caring about is an emotional response by all humans. Caring for is a set of actions or intervention we as nurses perform on a daily basis to meet the needs of our patient, while curing form is the role of the physician in removing the disease or resolving the condition of the patient. He expounded on the role differences that is essential for each one to work together, nurses and physician, for the improved patient outcome. Nurses is an integral part of the health team because nurses must be able to keep the patient alive by discovering in a consistent manner the caring for variables that will reduce the burden of science on how to cure the patient. Dr. Olson further explained the importance of why we have to understand the care variables or interventions that is imperative to understand how well the patient will do. In understanding the care variables, Dr. Olson likewise presented the cue response theory, emphasizing the importance of understanding the cues or the behavior that the patient exhibits, the intervention that we should provide at the right time, and the patient so that the patient can move towards recovery. He further identified some of the caring variables that is implemented by the nurses on the bedside and cited the importance of discovering the routine intervention which will move the patient towards or away the recovery of consciousness. In conclusion, I would like to say the evolution portrayed that bedside care for coma patients is a fusion of professional efforts from both physician and nurses. This discipline strive to provide cure and care to patients with injured consciousness to bring about the best outcomes so the patient can live an optimum quality of life. With this, I thank you for your kind attention.